Good afternoon, everybody, and welcome to Grand Rounds. Today, it is my pleasure to introduce Dr. John Hardie. Dr. Hardie is a radiation oncologist. He did his training at Mayo and has been a member of McFarland Clinic and on the staff at MGMC since 2016. And he has very kindly accepted our invitation today to provide us with an update on recent trends in radiation therapy for breast cancer. And please join me in welcoming Dr. John Hardie.
Hi, sorry for the slight delay. This is a fairly common situation. You're in a room with a patient and you're getting ready to leave and you put your hand on the doorknob and then you get a couple of questions. Anyway, we'll get started. So this is a summary of some recent changes in breast cancer treatment, but more than that, it's sort of an overview of some major themes in research and development in radiation oncology that are probably going to have changes across the whole discipline over the next few years. First thing, I have no disclosures. Nobody's paying me or anything for that. I mean, not that I'm not for sale, but nobody's offered. So this is going to be sort of a general talk rather than a specific one. I was asked specifically to talk about new developments this year in breast cancer. We had some really major developments in the last 2 years. There weren't really any spectacular ones this year, so this became more of a general talk. Because this is a general talk, I'm going to make a lot of drastic assumptions, a lot of simplifications, which are probably not completely justified, and I am going to shamelessly abuse statistics as well. By the way, Darrell Huff, How to Lie with Statistics is a fantastic book. You'll see some really horrible examples of statistical abuse there. And this is not strictly speaking going to be breast cancer. I'm going to talk about some other cancers as well. So there's a couple of big themes in radiation oncology over about the last 10 years or so, which have guided a lot of the research and a lot of the development in ways cancer is treated and the approach you take to patients. All right, the first one is dose intensification, and this is pretty much what it sounds. You put more dose into the cancer and you get better control. It's not quite as easy as that. There's the problem of damaging normal tissue. There's the problem of causing long-term toxicity from this, and so you have some subtleties that you have to deal with. Altered fractionation. Most of the traditional ways of treating radiation, of applying radiation to cancers were developed starting in about the 70s through the 80s and 90s, and at that point, targeting wasn't very good, and you had a lot of toxicity to deal with, and so what was found is you give small amounts of radiation over a very long period to try and minimize that. We've come a little ways since then. We have better targeting. We've got better understanding of how tissue responds to radiation. And so we're making changes in the way we deliver the radiation itself. And along those lines, the next thing is de-escalation. Once you have a treatment that works to control a cancer, the next thing you do is you try to see what you can back off on to keep the control where it is and cause less side effects, less toxicity. So that's the idea of de-escalation. There was another one on the handout that came out on the notification that was comprehensive radiation. I was going to talk a little bit about metastatic disease, but there really weren't any spectacular trials or results in that particular field in this last year. So basically, comprehensive radiation is the idea that if you can treat all sites of metastatic disease in a patient with local therapy, you get better local control. And that looks like it's going to turn out to be a really beneficial approach, but we have to see. Okay, dose intensification. Higher radiation doses provide better control of tumor at the possible cost of additional toxicity. The easiest way to do this is to just crank the dose up. This is called the brute force and ignorance method, and it's generally not the best idea, so we don't do it unless we have some other way of compensating. Another way is to change the fractionation to deliver a higher dose rate without necessarily increasing the total dose. But the way we usually do it is to improve the way we target. If you can find a better way to localize the cancer, a better way to line up to that target volume each day, a better way to avoid hitting the nearby normal tissues, then you have the freedom to increase the radiation dose to the tumor without increasing it to the surrounding tissues, and you end up with better results. Altered fractionation. This is a really important point in radiation. One thing that turns out to be true in the way tissues respond to radiation is that it is not just the physical radiation dose that matters. It's the biological response of the tissue to that radiation dose. And it's possible to pick some biologic parameter, tumor control or late toxicity or early toxicity or fibrosis or nerve damage, and you can adjust the rate of radiation being delivered and the number of fractions to keep that particular parameter constant for the course of treatment. So you have a treatment that is 6 weeks long that has exactly the same effect as one that's 3 weeks long. The difficulty is that the normal tissues, the toxicity rates, the tumor control, all respond differently to changes in the radiation dose rate and the number of dose fractions. And so you have to be really careful to work out how these are all going to change if you're changing the way the radiation is given. De-escalation. Deliver less treatment with the same disease control. All right, this is a good thing. There is an aphorism in computer design and computer programming that says the fastest and most reliable components of a computer system are the ones that are not there. Right? If you don't have it there, you don't have to worry about it. If we can get a patient cured of their cancer without needing to give them radiation, that's a win. And so the idea of de-escalation is to try to find the groups of patients who have low enough risk that we can decrease the amount of radiation or omit it completely, or find something like immune therapy that increases the overall cure rate, allowing us to decrease the radiation dose in compensation for that and end up with the same outcomes. Better targeting also helps us with that. If we can shrink the volume of tumor, then we are de-escalating the dose of radiation to the normal tissues, and we end up with the same control and better outcomes. All right, as a baseline, the standard conventional treatment for breast cancer splits into two parts, basically. The first is intact breast node-negative cancer. Lumpectomy and sentinel node biopsy is the surgery usually for this. Whole breast radiation is done. The nodes are not covered, and the radiation traditionally is 50 gray and 25 fractions. The majority of patients then get a surgical bed boost, which is escalating the dose to the area of the tumor and a small margin around that. And that's typically 10 to 16 gray in 5 to 8 additional fractions. So it ends up being 6 weeks, give or take. For node-positive disease, nodal volumes have to be covered. Typically, it's 50 gray and 25 fractions to the chest or breast and the nodal volumes. Right, this is a larger volume. It's generally a more toxic treatment. And again, if it's intact breast, you will deliver a surgical bed boost. If it's post-mastectomy, you generally don't. So here's an example of prostate cancer for dose escalation. The picture is not actually a prostate cancer patient, but this is the only 2D X-ray that I could find to use as an example. In the 80s and 90s, prostate cancer was typically treated to 60 to 66 gray with really wide fields. Three-dimensional planning wasn't available. Online imaging on the treatment machines wasn't available. And so you would take plain films and you didn't quite draw on them with crayon to figure out where you were going to give the radiation, but it's similar. And you end up with something that looks like these. You have these kind of box fields that cover essentially the whole pelvic volume, and that goes uniformly to this 60 to 66 gray dose. And you would get cure rates of about 50% in the majority of those patients. And there was quite a lot of toxicity because you're also hitting small bowel, large bowel, sigmoid, rectum, and bladder. And the reason that you went to 60 to 66 gray in these treatments was that the toxicity became unacceptable if you went above that. You were doing the best you can with the equipment that you had, but it was known to be not as good as it could be. With better targeting, which you can see over here in this lower volume, we have CT scans. We can target in 3 dimensions. We have onboard imaging so that we can match the setup on the treatment machine to the CT that we used for planning. And we can get much tighter radiation volumes that conform much more tightly to the prostate volume. We eliminate a lot of the dose to the rectum. You can see on this slice where the rectum is right next to the prostate, only a little bit of the radiation is getting the full treatment dose. And about a third of the rectum is getting half of the treatment dose. This gives us a lot less toxicity, a lot better control, and we can now get the radiation dose up to about 80 gray, so a good 30% higher than the previous one, and cure rates on average are 75 to 85+% for prostate cancers, all comers. And there's a whole lot less long-term toxicity with this kind of treatment. For breast cancer, you have a similar kind of thing. Traditional treatment was done with two-dimensional fields, plain films, and you basically drew a box to cover the breast volume. And the thing that's a little tricky about this is that the breast doesn't, if you're looking at an oblique film, the breast does not end at the chest wall. The tail of the breast and the axilla extends back to about here. And so you have to have your fields open enough to cover the entire volume of breast tissue. And if this is a left-sided cancer, the heart sits in that volume. And that can cause problems. It was very often necessary to reduce the volume that you are treating, which means that you are knowingly underdosing some of the breast tissue to meet the constraints for heart dose. Right, you're trading some possible cancer control for less risk of cardiac problems. It's not ideal, but it was the best that we had at the time. These days we can do more conformal planning. This is an example of three-dimensional planning. This is an example of IMRT. I'm not going to go into those in great details. IMRT is a lot more conformal than three-dimensional, but three-dimensional is a lot more conformal than two-dimensional. The end result here is that we allow the dose to conform more tightly to the chest wall. We're better able to avoid the heart. We're better able to avoid the lung. You end up with less long-term toxicity. The next question you have to ask is, does this actually matter? The answer is yeah, it does. So there's two studies, both retrospective. The first one was in the New England Journal and looked at 2,100 patients who were treated with two-dimensional and very early three-dimensional radiation and followed for a very long time, up to about 30 or 35 years, with a very close analysis of how these patients did with cardiac health over that time period. What they found was that there was a 7% relative increase in cardiac risk in this patient population per gray of mean heart dose. And the mean heart dose for these kinds of treatments is typically about 5 gray. So you get a 35% relative increase in cardiac risk after radiation for left-sided breast cancer. And this cardiac risk is anything from need for angioplasty to heart attacks to heart failure to cardiac death. So these are not trivial side effects. A second follow-up, our second study, Boero in 2016, looked at 29,000 patients treated with either modern 3D planning or IMRT. And what they found was that there was a 1% absolute risk in heart problems, but only for women who have significant heart problems and heart risks going into radiation. And this 1% showed up at 85 years old. So you have patients who are treated from their 40s up to their 80s. The risk only becomes significant towards the end of life, and it only increases by 1% in patients who have cardiac issues when they get their radiation. So this is a really, really big difference. Example, 70-year-old woman, smoker, on blood pressure medications, diabetes, high cholesterol. Using the up-to-date cardiac risk calculator, she has about a 28% risk of a significant cardiac event in the next 10 years. If she gets two-dimensional radiation, we increase that by 30% relative, giving her an overall risk of a serious heart issue in 10 years of about 38%, which is huge. The same patient with 3D or IMRT increases the risk by 1% to 29%. So the end result is that the breast cancer treatment will increase her cardiac risk from 28% to 29% instead of 28% to almost 38%. Right? Targeting really matters. The ability to conform the dose really makes a difference. Altered fractionation. All right, this is the part I like the best. I am a recycled physicist. I love math and statistics, but here you go. So we're going to talk about altered fractionation. To understand what this means, you have to have some idea of how radiation works. So here's a brief tutorial. Radiation kills cancer by causing double-strand breaks in DNA. With radiation, you can do that in two different ways, really. The first is you have a single radiation particle, a single photon or a single electron, coming through here that hits both strands at the same time and breaks both of them. The other possibility is two separate radiation events, two electrons, two photons come through, each of which hits one strand and each of which breaks one strand. Okay, the single photon event is generally immediately lethal to the cell. Double strand break repair is not very good. Single strand break repair is usually pretty good. So if you get an immediate double strand break, the cell is very unlikely to have that repaired by the time it tries to divide, and so it dies. The rate of this happening depends on the total amount of radiation that's being given, but because these both happen with a single particle coming through, the rate of single strand breaks this way does not depend on how fast you give the radiation. Just the total amount of radiation that you give. The other part does depend on the dose rate. If I fire, now, this is not the way to deliver radiation, but if I fire 1 electron at your tumor per day, the chance that I'm going to get a 2-strand break from 2 subsequent days before your cell repairs the DNA is pretty darn low. So that radiation is going to be very ineffective. On the other hand, if I crank up the machine, open up the jaws, and deliver a whopping big dose all at once, the chances of these two happening close enough together in time that the cell can't repair them goes up quite a bit. So this part here depends on the dose rate. This part here depends on the total dose given. And each individual cancer and each individual normal tissue responds to radiation in these two ways at different rates. Some cells are very, very good and very, very fast at repairing single strand breaks. They are less sensitive to this kind of damage. Some cells divide very slowly. They don't repair their DNA very quickly. They are more sensitive to these kinds of events. And so the way these respond to different dose rates varies from tissue to tissue and tumor to tumor. All right, here's a really boring table, sorry. So for the single photon double strand break, if you have cells that are dividing rapidly, almost 100% of them get killed by a single strand break like this. If you have slow cell division, you still have a pretty high percent kill, but sometimes cells get lucky and they can patch together a double strand DNA repair. The cell is generally going to have some damage. It will not be functioning normally, but it might survive. For the double photon double strand break, the percent kill depends very strongly on the dose rate, especially if the cell is dividing quickly. If the cell divides fast and the dose rate is low, then there's a pretty good chance that the cell will divide before the second hit comes, and so you get less kill that way. If the cell is dividing slowly, you have more chance of having a double strand break with 2 separate photons, but it depends a lot on the relative speed of the radiation dose rate and the cell division. All right, if the cell repairs its DNA quickly, there's not much effect if you break it with a single photon. If it repairs slowly, there's still not much effect if you break it with a single photon. Double strand breaks are just not so good. For double photon events, if you have rapid DNA repair, the cell is much more likely to survive than if it has slow DNA repair because it's more likely to repair one of these hits before the second one comes. Overall radiation dose affects the rate of single photon double strand breaks. It's proportional to the dose. Double strand breaks are proportional to the square of the dose because you need 2 hits. You get the dose rate for each one. The radiation dose rate doesn't affect the single photon double strand breaks at all, really. And it is very, very sensitive for the double photon double strand breaks. Okay, so this gives rise to this concept of a biologically effective dose. The radiation dose that we quote in units of gray is a measure of the absolute energy that we deposit in the tumor, right? That is a pure physical quantity, and it doesn't change no matter what you're aiming at. 1 gray is 1 gray no matter what you hit. But we're hitting a biological system which has mechanisms to repair the damage that we're giving. And so you have to understand the effect of the radiation, you have to also understand how the biological system responds to the physical damage it gets. When you take into account the biological response, you get something called the biologically effective dose. All right, we still quote it in gray, which is really not quite right, but we do it anyway. But you have to keep in mind whether you're talking about the biologically effective dose or the actual physical dose. All right, if you think about it, it takes a lot of work to figure out how all of these different tissues respond to different doses of radiation, different dose rates of radiation, and different dose energies of radiation. And this work has been ongoing since at least the 1940s, and we are just now starting to get a big enough database of knowledge about these that we can start using it to predict how systems are going to respond when you change the fractionation. So with apologies to Gertrude Stein, a gray is not a gray is not a gray. It depends on how the tissue responds to that damage and how you deliver it. All right, and actually, a gray is a gray. It's defined that way, so this whole slide is just confusing. All right, some examples. These are a couple of calculations of some prostate cancer doses. The first set for the prostate cancer, we give the same physical dose, 60 gray, to the prostate. We give it in 3 different fractions, which means 3 different dose rates. And then we calculate the effective dose. So 60 gray in 30 fractions has an effective dose of about 100 equivalent gray. 60 dose in 20 fractions, smaller number of fractions means higher dose rate. Gives you an effective dose of about 120 gray. So this has more effect on the prostate than this one does. And 60 gray in 15 fractions has an effective dose of about 140 equivalent gray, which is hotter still. You would expect our standard 85% cure rate with this one, maybe 88 or 90% with that one, and then maybe 90 to 92% with this one. Both of these are standard treatments that we're giving right now. This one is tested every now and again, but there aren't any studies that show that it's beneficial, especially when you consider toxicity. So I suspect we'll get to this one, but we're not there yet. For breast cancer, slightly different approach. We're looking for the same biologically effective dose with different physical doses and different fractionations. So this first line is the standard conventional treatment for breast cancer, 50 gray in 25 fractions, 2 gray per fraction. You get an effective dose of about 83 gray. Notice that you cannot compare an effective dose in breast cancer with an effective dose in prostate cancer because breast and prostate respond to radiation differently. Right? These are not the same values. This 100 gray for a prostate is not comparable to the 83 gray with the breast cancer. It's just a relative thing. You look for a given tissue and a given dose, you compare effective doses, but you can't compare across tissues. All right, another fractionation is about 43 gray in 16 fractions. The effective dose there is 82 gray. This is called Canadian fractionation, and it's one of the ones we use for breast cancer. And then you can look at 28.5 gray in 5 fractions, which also is 83 gray effective. And this is almost the dose that was used in a trial called the FAST trial, which gives radiation treatments for intact breast cancer node negative in 5 days. And this is now our standard of care. This is what we're doing for most patients who are coming in to see us. This trial here, the FAST trial and the Fast Forward trial, were both published within the last couple of years, and it has resulted in a major change in how breast cancer is treated in the United States. All right, never mind the units. You can't really compare them. They're just a way of measuring what's going on. Okay, so Whelan et al., this is the Canadian fractionation one. This was 4250 in 16 fractions compared to 50 gray in 25 fractions. And what you found was there was essentially no difference in toxicity, and the local control and survival were the same. So when this was published in 2010, there was a big shift from 50 and 25 to 4240 and 16, which improved the outcomes a lot. You get less toxicity with these shorter treatments. And then there's this one, the START trial. Haviland et al. In 2013 also looked at a 15 fraction treatment. So one was 16, one was 15. That's just a random thing they picked when they were designing the trial. When I'm talking to patients about this, they always ask, why 15 and why 16? And the answer is, I don't know. That's what they picked. In any case, this is 40 and 15. This is 42, 40, and 16. Again, no difference in local control, no difference in survival, but better toxicity with the shorter course. These were the first two randomized hypofractionation, smaller number of fractions trials, and they started this switch to shorter courses of radiation. Two of the more recent ones, this is the FAST trial, this is the Fast Forward trial. These are both 5 fraction treatments. The only difference is that one of them is given 1 fraction a week for 5 weeks, and one of them is given 1 fraction a day for 5 days. Fast Forward is 5 days in a row, Fast is once a week. The doses are a little bit different because this equivalent dose depends not only on how much dose you're giving and how fast you're giving it, but whether there's any recovery time between doses for the tissue that's getting radiated. If I give you a fraction today and another one tomorrow, you get more effect than if I give you a fraction today and another one in a month. So both of these showed that 5 fraction treatments are effective, both are safe, both have less toxicity, and we are using Fast Forward 5 fractions in a row, 5 days in a row, as our standard treatment for early stage breast cancer right now. All right, for ultra-hyperfractionation, the toxicity question is open. There was a study, the issue here is that both the FAST and the Fast Forward trial checked 2 dose rates in 5 fractions, and both of them found worse toxicity with the larger dose rate. There were a couple of other trials that looked at those 5 fraction treatments, comparing a couple of different doses, and found no difference in toxicity. So it's unclear how much range we have on these doses. Right? We know we can do a 5 fraction treatment with less toxicity than conventional radiation. What we don't know yet is if we can dose escalate that. Can we take that 5 fraction dose and increase it to get better tumor control? And that question is open, is not resolved yet. Another way of looking at this is to radiate, rather than radiating the whole breast, radiate part of it, the part of it that's at highest risk of recurrence. This is the idea of partial breast radiation, and this trial here, the Florence trial, was the one that showed that that was really effective and safe in patients with low enough risk. There's a set of criteria for this. I'm not going to go into those. It has to do with ER positivity, patient age, grade of tumor, location of margins, wideness of margins, various other things. But if a patient is eligible for that, if a patient fits in those criteria, then it is entirely possible to treat their early stage breast cancer radiating the tumor bed and a small volume around it rather than the whole breast. That really reduces the toxicity of this treatment, and it does not compromise your chance of a cure, provided that the patient fits into this low risk group. So, as far as fractionation in breast cancer goes, for node positive and post mastectomy, the results are not completely clear. We are treating node positive breast cancer in 15 treatments now instead of 25. The data is pretty clear that that works. There is not a definitive phase 3 trial for this yet. There are a couple pending. START A and START B both included node positive patients, and those node positive patients on subgroup analysis had the same outcomes as patients treated with the longer course of radiation. There's only one published phase 3 trial showing good results of this. There are multiple retrospective and phase 2 trials also showing that the shorter course of radiation works for node positive. And decreased toxicity seems to work, but there are a couple of really large definitive trials that are in the works for this particular question. So Wang et al. Is the phase 3 randomized control trial. As breast cancer trials go, it's not a particularly large one. It has 820 patients. Most really definitive breast cancer trials are having 2,000, 5,000, 10,000 patients. And the reason for that is that the event rate is so low. I mean, early stage breast cancer has a very, very high cure rate, and you need to have a large number of patients in order to see the small number that are going to be recurring. This Koulis et al. Is a retrospective study of about 5,800 patients. 4,000 of them got hypofractionated and 1,500 got conventional, and there was essentially no difference between them. DeMatteis is a single-arm trial. It's phase 2, and that showed good outcomes with the shorter course of radiation for node positive. And Distaquira is a single-arm trial, including stage 1, stage 2, and stage 3. Those are node positive patients. Lumpectomy and mastectomy, so this is chest wall and intact breast. And they were looking at 2 different hypofractionated regimens, and they didn't find any difference between them. So all of this is really suggestive. I suspect that there will be a universal shift to shorter courses of radiation for node-positive patients as well over the next couple of years, particularly as these larger trials get published. Some centers are switching now, some centers are waiting to see what happens, but I think there's going to be another change coming for these. Okay, de-escalation. For breast cancer, there are 2 questions here. Are there any breast cancer patients where we can omit radiation altogether? Well, we know one group, a woman who has early stage breast cancer, node negative, no positive margins, no skin wall involvement, no chest wall involvement, and a mastectomy does not need radiation. It's a pretty drastic treatment to try to avoid 5 days of radiation, but you can. The second question is, are there patients who don't benefit from a boost? A boost is shown to be beneficial in most breast cancer patients. The idea is that if you're treating the whole breast, the area around the surgical cavity is the area that's at the highest risk of having a residual disease, and you can get an increased cure rate if you give additional radiation to that area. The question then is, why not just give the additional radiation to the whole breast? And the answer is that the toxicity goes up if you do that. So it's a balance between doing some focal radiation to try and increase the cure rate, but in a small enough volume that you don't increase the overall toxicity. All right, so emission of radiation. In early breast cancer, there are 2 really critical trials here, the CALGB and the PRIME. These both looked at quote-unquote elderly patients. Since I am technically elderly, I don't really like that designation. These are patients between 65 and 70 years old or older who had very early stage breast cancer, low risk. And both of these trials looked at 500 to 1,000 patients and looked at the possibility of completely omitting radiation in these patients, assuming that they will continue with anti-estrogen therapy for 5 years, which turned out not to be the case. A significant number of them stopped taking that after about 2 years for good reason, right? It's not pleasant. In any case, both of these trials showed the same thing. You get an increased risk of local recurrence at 10 years by omitting radiation, but the overall survival and the distant metastasis-free survival was unchanged. So radiation in this population prevented some local recurrences, but did not improve lifespan and did not improve the chance of getting metastatic disease. So it's safe, based on these trials, to omit radiation in low-risk older patients. And for a long time, that's what we've been doing. But not so fast. The CALGB trial was a 1990s cohort. PRIME 2 was a 2000s cohort. And a 70-year-old in 1990 is not the same thing as a 70-year-old in 2020. First of all, the population's bigger. Second of all, people are healthier. Third of all, the treatment of comorbid conditions has gotten a lot better. And the main reason that you didn't see an increase in death rates in the previous trial was that the competing risk of dying from something else in that population was big enough that it masked the increased deaths from cancer. They became non-statistically significant. There was a really big meta-analysis, several 100,000 patients followed over a very long time, that came up with a really nice result here that says that if you can prevent 4 local recurrences at 5 years, you will prevent 1 death from breast cancer at 15 years. And this is universally applicable. I mean, it's It may not be exactly 4, there's some fudge there, but basically 4 local recurrences prevented means 1 death prevented. But there's a 10-year delay between the local recurrence and the death. So looking at the population, there should be a 2 to 3% increase in breast cancer specific survival at 15 years in patients who are 70 and older. About 10% of them recur locally. About 2.5% are at risk for death based on this 4-to-1 ratio here. Both of those long-term studies followed for 10 years and then stopped. There's the first problem. The deaths don't get seen until 15 years out. The second problem is that in the earlier, particularly the 1990s population, the majority of the patients in those studies did not survive long enough to die from their breast cancer. Looking at life tables, what we find is in 1990, there were 127 women, 18.7 million of them. No, there were 127 million women. 18 million of them were above 65. In 2020, there are 166 million women, and 30 million of them are above 65. So the population in this group is growing. It's basically doubled since the first trial was done. You have more patients in this population, and that means you are inherently going to get more recurrences and more patients who will die from their breast cancer in this group. The second thing is looking at life expectancy. In 1990, the life expectancy of a 70-year-old woman was about 14 years. In 2022, the life expectancy is between 17 and 20 years. So not only are there more patients in this group, they are living quite a bit longer. And if you remember that meta-analysis, the increased death rate shows up at 15 years. The 1990 group didn't live that long. The current group definitely does. So for now, for a patient who's 70 years old now and is looking at the possibility of emitting radiation, it really, really matters what kind of health they're in. If they are staggering along with heart failure, renal failure, 1 lung, 1 kidney, and 1 leg, you can probably omit it. If they're in good health and they're out training for a marathon, you probably shouldn't, because they are very likely to still be here to have the effects show up of emitting that radiation. In addition, in 1990, if you were getting radiation, you were getting 6 weeks of radiation with the really significant side effects that went along with it. If you come into our department today, you're going to get 5 days of radiation with almost no side effects. And a lot of these patients will be eligible for the partial breast radiation, which really has almost no side effects. So the whole situation has changed. The toxicity has changed, the treatments have changed, the population has changed, and these really landmark trials are becoming marginally not applicable anymore. There are a couple of trials going on now. Whalen et al., you might recognize him from the guy who did the hypofractionation trial. He's doing the Lumina trial, and then there's the Prospect trial. These are looking at omission of radiation in low-risk patients now. There's another one, do I have it here? BR007 and the Precision trial are also ongoing, looking at these results. We have to wait and see how these turn out, but it is probably going to show that there are some very low-risk patients who we're going to be identifying with gene assays, like most likely things like the Oncotype, who can emit radiation, and there are going to be a lot of patients who were on those previous omission trials who shouldn't. All right, we're still going to have some that can emit it and some that don't, but the populations are going to be very different, and we really have to wait and see what's going on now. So my default right now is to give radiation rather than omit it, even in patients who met the criteria for that previous trial. All right, how about omitting it after chemotherapy? So this is another question. In the 1990s and 2000s, if you had node-positive breast cancer, you had surgery. If you were node-positive, then you had chemotherapy and then radiation. There were a couple of trials showing that you get a lot of information if you do the chemotherapy before surgery. And then the question comes up, the chemotherapy is effective enough that there's a significant number of those patients that have a complete pathologic response to the chemotherapy. So they get diagnosed with node-positive breast cancer at diagnosis, and that's biopsy proven. They get their chemotherapy, they have surgery, and there's no breast cancer anywhere. Do those patients need radiation or not? We don't know. This B51 trial, everybody is anxiously waiting. It tested exactly this. It's a very large randomized control phase 3 trial that randomized to radiation or not in patients who were diagnosed with node-positive breast cancer and had a complete response to chemotherapy. That trial just recently finished accruing. We're going to have probably a good 4 or 5 years for their first analysis point. I have no idea whether this is going to be positive or not. A lot of trials, when you read them, you have some idea of which way you think it's going to go. I really don't know. But this one is going to be a practice-altering trial if it becomes positive. This is going to be a large population of women who are responding well to chemotherapy, and chemotherapy is getting more and more effective every day, who may end up not needing the 4 or 5 weeks of radiation that they would get otherwise. And that would be a huge change. I'm hoping this one turns out to be positive. I have no idea whether it will or not. I'm sort of holding my breath waiting for it. So the next question that we talked is, who needs a boost? Dose intensification or de-escalation? Do we need to give it to them or not? There was the EORTC boost trial published in 2015 that looked at this question, randomized to standard radiation with or without a boost. And what they found was that there was a significant difference in local recurrence, 12% with the boost versus 16% without. First local recurrence, 9% versus 13%. No significant difference in overall survival, but there was a 4 times bigger risk of significant fibrosis after the boost. So you would have a definite proven trade-off here. You have a lower risk of recurrence with the boost, but you get more toxicity. So looking at all of the subgroups in this, you get about a 20% to 30% relative risk reduction of local recurrence, with about a 20% absolute risk of fibrosis from the boost. So this means that you have to consider this on a case-by-case basis. Going back to those 2 patients we talked about before, if you have a patient that's 95 with heart failure, kidney failure, and 1 leg who likes sword fighting, you probably don't need to give them a boost. If you have a 45-year-old with an aggressive-looking cancer who's in very good health, they probably do need one. And so you can't have, right now there is no clear guideline, yes or no. It's on a case-by-case basis. These are the 2 examples I just gave you. The first one's in good health, 2.5 centimeter, big tumor, high risk. Recurrence risk is about 10% or 12% at 10 years. Fibrosis risk is about 20%. Boost reduces the recurrence risk to about 9% from 12%. That's probably a win. That's a good thing. 78-year-old in poor health with a low-risk tumor. The recurrence risk is about 2.9% at 10 years without a boost. It reduces to 1.9% with a boost with a 20% risk of fibrosis. Probably not a win for this patient. So I would recommend a boost to the first patient, but not to the second. So Chua et al. Randomized for DCIS to dose escalation with a boost or without. They all got either conventional or hypofractionated radiation, and they were randomized to plus or minus a boost. 5-year result showed that there was a 97% freedom from recurrence in the group that did get a boost, and a 92% freedom from recurrence in the group that did not get a boost. So you have a 5% absolute difference in local recurrence rate in this population. So this one suggests that you probably do need a boost. On the other hand, this next trial, looking at 1,000 patients, HER2 positive, 441 with a boost, 641 without. The 11-year local control was 93% versus 91%, so maybe you don't. All right, there are ongoing trials for this too. They're not going to be published for a while, so this is going to be an open question, and it's going to be dealt with on a case-by-case basis. Hopefully the trials will give us some real clear guidelines on who needs it and who doesn't. We'll have to see. So in conclusion, dose intensification, altered fractionation, and de-escalation are kind of standard themes in trying to change the way we do radiation to minimize toxicity and improve control. These have been really successful over the last 10 years in completely altering the way we deliver radiation for breast cancer for almost all breast cancer patients. The majority of low-risk patients are getting 5 fractions. The majority of higher-risk patients are getting 15 fractions. Almost nobody gets the traditional 25 gray or 30 gray, or 25 fraction or 30 fraction anymore. As usual, there are open questions. Things get more complicated as you learn more, and we still have a lot to work out on the groups that these apply to. Any questions?
There are no questions online.
Okay. All right.
Thank you very much.
Thank you very much.